of an effective medical director, assistant professor in the Department of Family Practice at Oregon Health and Science University, and he's board certified in geriatrics. He's the past president of the Oregon Geriatric Society and a geriatrician in private practice in Portland since 1993. Welcome, Harry Krulewitch.
Good morning, everyone. I've been asked to talk about how to improve nursing home safety collaboration efforts with QAPI, and my focus today is not actually going to be on specific safety interventions, whether it's falls, restraints, or other activities, but what is the structure and process of leadership that your medical director can take, and how can you help create a process of collaboration to address those issues more effectively? To start out as an example, the Pearl, which is one of the homes of the Park-Avamere companies, is a place that I've worked at for over 10 years, and we've taken on as a big challenge in the last few years how to reduce readmissions as part of their approach to contracting with acute hospitals. And I wanted to show one of the data sets. Here's our team that you actually saw up there, which includes, in this particular picture, a speech therapist, social worker, director of rehab, the RCM, and an OT worker. Not unusual that we would get this team together once a week, and I'll talk about that in a bit. But our team was asked as part of the QAPI project to address the readmission program. And you can see that here we were able to actually take, in a very busy post-acute care setting, you can imagine our length of stay was 10 days in this post-acute care. It was not unusual for me to have 12 to 15 admissions per week directly out of the hospital. And we were able to effectively reduce our readmission rate from almost 17% to 10% with a specific QAPI program of identifying low, medium, and high-risk patients and targeting them. But the key was, how did we create a team that could do that? To do this team effectively, I integrated with my own research principles of person-centered care, palliative care, and chronic disease management into the weekly care planning that the team took on for these patients. My second talk is going to focus on how we actually use elements of these new features of geriatric care. But today's talk is to focus on how do we set up the structure and the process of that team so that we can use these principles effectively. Before we even talk about, however, the team that we're creating, we need to be honest about what are the barriers that we're facing to do any kind of leadership change in a nursing home setting. And this should not come as any surprise to you, but I think it bears mentioning each of these because these could each break your team effort. First off, the nursing home goals and structure do restrict autonomy and participation. I know, and you know, that your patients are often impaired, vulnerable, cognitively impaired, have disabilities, chronic acute problems. The families are expecting a great deal of service. The last thing they may want, or the patients may be capable of, are making any effective participation that enhances or improves their sense of autonomy and functioning. Nonetheless, even in this environment, we've got to find a way in a rehabilitation setting to create a higher sense of participation. The physician leadership skills, I think, are really critical. We know that doctors start out in medical school residency program where they are seriously trained, supervised, and graded in taking complete control of their decision-making process. They are not encouraged to promote collaborative efforts. This can lead, unfortunately, to even serious dysfunctional behaviors where they might be abusive or even minimize the efforts of other disciplines and only look at their own control of a situation. This undermines the effective team, and quite frankly, you know and I know that geriatrics is a team sport. There's no way the best doctor can possibly address all the different disciplines that go into good care and the paraprofessional and family roles, because these patients depend on a wide range of informal and formal networks, which sometimes can be far more important than anything that doctor is doing. But a leadership skill that minimizes or insults or avoids working with all of those other disciplines is going to undermine any effective care team. So then you have the historical role of physician versus nurse, where your nurses might even want the physician to be in control and feel threatened or frightened by a physician that expects them to take on a leadership role, and the physician themselves may not be comfortable delegating to other people. Your disease-based treatment protocols reinforce these leadership skills because disease-based treatments require the physician to be initiating all of the decisions. And again, we now have evidence that multiple disease-based interventions lead to sometimes unnecessary or harmful interventions in the older adult. So even if you're following as a doctor the right protocol for one disease after another, you maybe end up subjecting your patient to needless admissions, interventions, and harm, none of which are going to enhance their chance of getting home and functioning effectively. The medical director realities make this even more of a problem because you know that doctors like myself are busy working throughout the community and the hospital and their own practice. Medicare reimbursements are very low, worse, quite frankly, in Oregon, as you know, than in the rest of the country. So there's very little financial incentive for your medical director to function as a team leader where it would take more time and effort to support and delegate to other people when he or she may just want to get in, get out, write orders, and get back to their own office. A consumer mindset permeates the entire long-term care model because the patients and families expect to be cared for. You're trying to provide high-level care. And again, this creates a passive set of behaviors for the patient. The reimbursement structure we've already talked about. And in the end, I think the most important statement that bears repeating over and over again, which we all know but doesn't seem to ever be addressed, is that good geriatric care, the cost of good geriatric care, is essentially case management. No one's paying for it, no one wants to pay for it, but someone has to step up and do it. So the solution to creating a patient-centered care model and a chronic disease palliative care intervention program is going to require some change in this traditional structure that can get at these barriers. And I want to look at the structure and process that I've learned to put in place and ask to share with you today that you're not going to find in any textbook or, quite frankly, that I've seen in any significant national workshops that focus more on the protocols that reduce utilization and improve QAPI. The first thing that I do when I go into a SNF, and that I've done at the Pearl for 10 years, is I review the boilerplate contracts. I get a boilerplate, you've got them, we all know what they are, how much money the doctor is going to get paid for showing up in your home and seeing patients. But I want that boilerplate to address specific aspects of effective patient-centered care. Those aspects are going to be discussed in the next slide, but I'm going to ask the home to create the designation of an RCM to round with me, identified as the geriatric champion for your facility. I'm going to ask that time be set aside for the team called the IDG, the Interdisciplinary Group, to meet, and we'll discuss more about that in the next slide also. But without having a person assigned to round with me and a team that I can work with, the staff are going to feel pressured by me because they know that they've got a lot to do, and they're going to feel like it's not in their job description. You're going to feel like I'm pulling them away from valued time, and a labor conflict will occur between my expectations of the staff and what they need to do to get their job done. On the other hand, if we both agree that there needs to be a leadership role for the nurse and an IDG set aside to work with me, this sends a signal to the nursing home staff that we value that activity and we value their professional involvement in it. The other thing that I'm going to need is that there be some statement that states that the facility actually is committed to chronic disease management and patient-centered care in the strategic plan. I know your strategic plans all read with lots of lofty goals and wonderful statements, but I need one of those statements to include this specifically so that we can all come back to it to state that we're, even on record, committed in the strategic plan to creating this kind of care in your facility. So let's look more carefully at what the contract is asking the doctor in the nursing home to do. The physician is going to be expected, that's me, to identify a nurse from my office, just like I'm asking you to set your RCM aside, which could pull her away from costs and activities that you want her to pursue. I'm asking myself to set aside one of my office nurses to be a liaison. Quite frankly, I've learned over 30 years that nurse-to-nurse communication is invaluable. And trying to have me go to a nurse or your nurse call me at my office sometimes isn't as effective. Nurses have their own discipline. They understand and have a language that they trust. and it's really critical to create that liaison. More importantly, even than having the nurse-nurse liaison professionally, is the commitment to relationship building. Because quite often, I'm too busy in my office, and I know that the families are going to be calling my office nurse for discharge planning, finding out information about what nursing home to go to, equipment, all types of activities. And if that nurse can have a liaison to the RCM, then she's plugged directly into the care plan and the discharge planning, and it bypasses me and is much more effective. The second thing is that by doing this, I'm disseminating information to my office nurse that she can disseminate very effectively to all of the families and the rest of my office. Next is conduct biweekly rounds. It's absolutely critical in a skilled unit, unless it's very small, that I be there not once, but probably twice a week myself, because patients are critical coming out of the hospital now and are not going to be stable for 7 days at a time. So I need to be able to make biweekly rounds. If I'm making biweekly rounds, I need to be rounding with that RCM each time I do that. As I've said before, having the RCM rounding with me is really critical. I'll discuss that in the next slide. But looking at a few other elements on this slide, all patients need to be worked up within 72 hours. The federal regs require 30-day notes. But I can tell you as a medical director how difficult and dangerous it is to have a patient discharged from the ICU who's been seen every day by 2 or 3 doctors, possibly rounds of doctors and fellows, who ends up in your SNF, and then the doctor says, I'll be there in a week or 2. Not only is that patient at risk for a very severe complication because they haven't been addressed promptly, but the family is going to be very frightened and irate that they've gone from a setting of very high physician contact to one where they almost are going to feel abandoned, waiting for the nursing home doctor to show up. And I think it's a liability issue. So we actually write the commitment into the contract that I will be expected to see that patient within 72 hours as part of the QAPI goals that we're trying to reach. Then we've already talked about having a weekly care conference and, if necessary, a palliative care conference. I want to point out this is not morning report. This is a weekly meeting where I am with a group of your specialists from the nursing home, and we identify who those patients are. We'll talk a little bit more about that in the next slide. And from that meeting, we might even designate patients that are at high risk of dying or need hospice care, or even just struggling with declines in their overall goals of care and need to discuss for the first time that they might not recover and what their goals as human beings might be. We want to commit to ongoing training. As I said, neither the nurse nor the doctor have training in their disciplines when they go to school on how to be effective collaborative team leaders. You can't assume that either your nurse or doctor, however motivated, will learn how to get along with each other and be role models for the rest of your organization. So they're going to need ongoing training, as well as a commitment to how to integrate geriatric assessment, palliative care, and chronic disease and QAPI principles, and not just assume that by meeting with you that they know how to do that. Some of the best places for this training not only are the October conferences at the Oregon Geriatric Society that are in Bend, but even more importantly, at the AMDA national conferences, where you can go online and look up the post-acute care division and find out where all the different regional trainings are for leadership in post-acute care. Lastly, it's my obligation in my contract to provide written monthly call coverage that's sent to every nursing home station that identifies who's on call every day and night and what the fax lines are for the resident care managers to reach my office 24 hours a day. Let's look at what I'm asking the nursing home director, you folks, to do. We talked about identifying the RCM nursing home champion. I know that this is a big gamble on your part because you are not reimbursed like the hospital. And I know that you have given your nurses a tremendous amount of responsibility. And the last thing you want to do is pull them out for an hour or two of rounding with me once or twice a week or a care conference. But I can tell you, both at the Pearl and at Providence, when I worked at Elder Place for 10 years, although we did get stiff opposition at first, we were able to show within months that we had improved patient satisfaction, improved family satisfaction, improved staff satisfaction, and we met earlier than expected QAPI goals of improved financial performance and improved outcomes because we had a leadership and team plan in place that pulled out everyone's efforts effectively. And we won over even the most resistant senior management who didn't want to have people doing this. The nursing home is responsible for disseminating new knowledge around these principles to the nursing home staff, and sometimes I would provide workshops on chronic disease management, palliative care. Sometimes the nursing home's own leadership would come in and provide that leadership. We talked about the weekly case conference. Again, it's not the morning report. They've got enough to do to get the morning report for your proper nursing home function. This is a separate weekly conference. In that weekly conference, we would use special tools that we'll discuss in the next talk to identify low, medium, and high-risk cases. Target the patients that might be discharged, target patients that had problems with end-of-life issues for palliative care conferences, focus on discharge planning, and all of the different tasks that the whole team needed to do to work with those patients and come up with an effective care plan. And last, we would use this team during the week to deal with quarterly QAPI goals. I think it's important for me to let you folks honestly know that this team would put the QAPI goals at the bottom of the list unless they were integrated into the weekly activities of the team. We did not feel that those QAPI goals meant a lot if they weren't something we were tackling on a weekly basis. And concurrently, when we did tackle them on a weekly basis, we really were able to effectively address them successfully. We talked about a commitment to ongoing training and staff development. Again, your staff is turning over. People can be trained and then move on. They graduate to school, they go back to other jobs, or you move them up to other positions. So there needs to be an ongoing commitment, which is a budgetary issue. But I often find that the really quality nursing homes have webinars and training programs easily available to come in on a quarterly basis and train staff, and I also do this myself. Lastly, it's essential because the evidence shows that polypharmacy will lead to worsening outcomes for our patients, increased costs, readmissions, complications, that the pharmacist has to be a part of the IDG. Now, I know that nursing homes have different types of contracts, so I have to leave this up to the nursing home management, you folks, to decide at what level the pharmacist can be involved. I obviously would like the pharmacist there every week. I know that's not feasible for most of our facilities. But if they are going to come just to the quarterly QAPI, we need to set aside time for them to look at the written reports for polypharmacy and not just mail them to me through fax lines throughout the week. But if they could even come once a month to the weekly meetings, they'll get a much better feel for what we're trying to do, and they can contribute more effectively. And I often found that when they did that, they wanted to come because they could see that they were having a real impact on the care plan. So the processes we want to have in place for patient-centered care are weekly rounding, time set aside for an IDG to do specific case management planning. From the case management planning, a few cases are going to be then further identified for palliative care conferences with family and staff. We're going to want to have the QAPI goals integrated into the weekly projects that we're working on. We want to have a nurse liaison from my office working with the RCM in the nursing home. And we want to have an ongoing plan for staff development and training in team leadership and collaboration. The IDG group that we work with is pretty straightforward. You've all got this already. The physician and the nurse practitioners are making rounds. One or both should be coming to the IDG so that they're not kept out. Sometimes the nurse practitioner would say, well, I don't want to go, you're going. And I would say, I need you to go because you're relationship building. I know that we're both covering that patient care, but it's important that the nurses know that you're there so that they know that you value their contribution. If you tell them you care about them, but you never show up, that sends a perverse incentive that you're not really part of the team and don't value them being there. So I like to have the nurse practitioner come to some, if not all, the meetings along with me. The RCM is absolutely critical, and her or his leadership is going to continue to grow by being at this meeting. The nursing director does not have to be at the meeting, but a number of facilities I found they wanted to be there, probably because the nursing director wanted to see what we were up to, but also because some nursing directors care about the care plan, and others have other interests in seeing how the whole function is going. The pharmacist we already talked about, I hope can come at least monthly. The social worker is critical because we're looking at both how the family plays into the person's recovery in chronic disease, which is a very major role, and also when the person might be experiencing deterioration or inability to meet their goals. They may need a palliative care conference, and the family is going to have an increased role as caregiver for those patients. And lastly, all discharge planning involves family care members, so we need that social worker there. The rehab director is also critical because we're trying to integrate the rehab plan into the discharge plan. And then sometimes there's optional team members that I ask if I know a case is coming up. Dietary, community home care people are invited in, which, by the way, is a remarkably effective way to have marketing and to promote your organization. Your speech therapy and chaplains from other organizations sometimes are also needed because of unique problems that we're running up to. Your outcomes can be integrated by the director of nursing. In this case, we're talking about readmissions at every week, and you want to make sure that the team is familiar with specific measured outcomes for QAPI and not just something they hear about every 3 or 4 months at a QAPI meeting. We talked about reduced hospitalizations at every weekly meeting so that we were able to keep it in focus along with the care plan. And that way we actually, as you saw, were able to make results within 1 quarter and have continued to make results throughout the year. So it's not something we just put off and discuss at a quarterly meeting, out of sight, out of mind. Instead, you want easily identified outcome measures that can be integrated into your weekly team meeting. And your IDG essentially will function as an active QAPI rather than something people are bored with and don't really want to attend except to get a free lunch and go back to work. In summary, we want to be designating nurse champions from both the doctor's office and the nursing home who will create a dyad relationship that will be unique and doesn't exist right now in any contract that I've seen. You want to conduct weekly rounds with the nursing home RCM, enhancing his or her leadership role. And quite frankly, to highlight that again, I did mention in the past, I do that also because that nurse is going to give me information that I don't have. At least once a week, a nurse says, Dr. Krulewitch, that drug has been tried. That doctor has been used. That effort isn't working. It would be really a bad situation if I started a plan and the family called me a day later saying, why are you doing something that doesn't work? Instead, that nurse is giving me a lot of advice. In addition, I know she's going to implement that plan 24 hours a day, and I need her to understand why I'm doing it. The family's going to ask her, why did he double the Lasix? Why did he stop the Dilantin? Why isn't he letting mom use a cane? Why do we have to use a 4-point walker? And it's important for the nurse to know what I'm up to and what I'm thinking, because she or he is going to be educating those families all week long. And lastly, you need a commitment to ongoing training. We've talked about that. And you want to set clear expectations in the contract with your pharmacist to participate not just in the QAPI, but with the IDG process in some effective manner. Thank you. The final next steps then, you want to meet with your nursing home team and designate who the RCM is going to be that's going to make rounds, and let him or her know that that is an expectation that will be protected and that they won't be punished or discouraged from doing that. And you want the contract with the doctor to also explicitly state that he or she will be rounding with that RCM, as well as providing the call panel and attending the IDG, not making that optional, as well as attending occasional palliative care conferences. And you want to meet with your medical director to review your expectations and to come to a common agreement before they get started in your facility.
Thank you very much, Dr. Krulewitch.